We're going to go through a fair amount of information pretty quickly. Here's the agenda. I'll start with an overview, then Josh Solomon and Jeremy Goldhuber-Fieber are going to talk about the modeling they're doing. We're going to see a video of Jason Wang about his work in Taiwan and how Taiwan very effectively dealt with COVID. He is in clinic now. Michelle's going to talk about our response and how our federalist system public health governance has or has not worked. And Paul will talk about confronting COVID-19 in low resource communities. We'll have Q&A at the end, and you can use if you go down to your bottom of your screen, there's a Q&A section. I want to encourage you to go ahead. We should have time for some questions. We'll try to get through as many as we can. You can uprate questions usually, and that'll help us sort of see what the highest priority questions are. So if we can have the next slide. So these are just some of the projects going on at Stanford Health Policy. They're not by any means all of them. We'll talk about a few of them today. So modeling we'll talk about. Aran Ben David and Jay Bhattacharya are leading a very, very important project to find out how many to test about 2,500 people in the county to determine if they have antibodies, which would indicate whether they've been infected. They're doing that today and tomorrow and expecting to test about 1,200 people a day. We have people working on behavior, attitudes, the economic fallout, digital technology and the public health response, legal and regulatory. Next slide, please, Beth. We have people looking at low-income countries. Paul's going to talk to us on the domestic front. Lee Sanders and others are working on community and health system needs. And then 3 projects that Paul is involved in with other folks at FSI. So I just want to provide this list, encourage you to reach out to any of us if you're interested in any of these. Many of the people across FSI are going to have tremendous skills and expertise to add to some of these very hard questions. So please let us know. Next slide. I'm going to start with a very brief overview of epidemiology and then the mathematics of infectious disease epidemics. And I'll explain why I want to do the mathematics in a little bit. It's very, very crucial to understanding what's unfolding before us. So as you all know, the coronavirus is highly transmissible, very infectious. About 80% of the cases are mild and many are probably asymptomatic, possibly a quarter, although that number is uncertain. Unfortunately though, 15 to 20% of people have severe disease. And of course, a number of people have died. The mortality is uncertain because we don't know how many people who have been actually infected, but it's significant. Transmission, we know, occurs from both people that are asymptomatic and symptomatic. And we also know that transmission occurs by droplets like sneezing, but it also occurs by what we call aerosol transmission. And this is where tiny suspended droplets can hang in the air. That's a problem. It's a more challenging situation in terms of isolating and preventing that kind of infection. And so that's one of the aspects that make this so very, very challenging in terms of containing the transmission. All right, let me talk about the mathematics of the infectious disease epidemics. The reason to give this background, the reason that it's important, is because it kind of dictates what we're going to see and what we have already seen. So very simple models of infectious disease epidemics look something like this, where you have these boxes represent different groups within the population. People start off as susceptible, they get infected, then they can recover or die. And let me show you this now in this graph, sort of how this would typically work for an infectious disease epidemic. The y-axis in this graph is the number of people, the x-axis is time, and the different lines on the graph show different groups. But take a look at the red line, and that's the people that are infected. And what you see is a slow start right over there to the left when the epidemic first starts, and then this dramatically fast increase in the number of people. How fast that is depends on the disease, but what we're seeing in coronavirus is that it is extraordinarily fast. And the green line is the number of people who have recovered. But you see that that goes up very quickly. That represents the total number of people been infected. And if you're going to act, you have to act before, well, you want to try to act before you get to this steep increase, because once you do that, once you get there, then it's much, much harder. And so the urgency to act is mandated by the way these epidemics unfold. So we can have the next slide. So this is from today's New York Times. There are two panels here. On the left is confirmed cases by area. On the y-axis of both graphs is the number of people. It's a log scale in this graph on the left, going up to 100,000 people. And these gray lines indicate the doubling time of the epidemic. That's another way to think of it. So the doubling time is just what it says. How long does it take for the epidemic to double in size? And so these gray lines say it's cases double every day, every 2 days, every 3 days. And you see different places graphed along these. And what you see is a cluster of in Detroit, New Orleans, Los Angeles, where they're doubling every 3 days. That's remarkably fast. New York, for up until recently, was doubling every 2 days or even faster. So just think about those numbers for a minute. And early on, when you start off, you have, let's say you have 2 cases, and 2 more days you have 4 cases, and 2 more days you have 8 cases. But when you have 10,000 cases, in 2 days you have 20,000 cases, and in 2 more days you have 40,000. There's this dramatic, very rapid increase in the growth of the epidemic, and that is what we are struggling against. The right-hand graph is the deaths by metro area. And again, on the y-axis is numbers, and this is days. And if you look at New York in the yellow, you see that the number of deaths is doubling between every 2 and every 3 days. That's a kind of shocking number. Today, New York has reported 3,000 deaths. And if they stay on this curve, you hope it bends to the right. But if they stay on this curve, that means about every 3 days, we can expect that death rate to double. It's 3,000 now, so that means in 3 days, be closer to 6,000. Just want to pause for a minute. Now, these are not numbers, these are people, healthcare workers, friends, relatives, colleagues, and to just reflect on the gravity of this tragedy unfolding before our eyes. And so we're sending our love and care to all these people in all these cities. It is something that we have never witnessed before, I would say. All right, if we could have the next slide. So what can we do? The situation in New York is worse than other places, but what can we do and what can other places do? And it really falls into social distancing. Social distancing is one of the most important tools to mitigate the effects of an infectious disease epidemic. And that means things like self-isolation, if you're sick, quarantine, if you've been exposed, shelter in place, all the things that we are doing right now. It has 2 main goals. The first is to reduce the total number of infections and thereby prevent sickness and death. But a second super critical goal is to slow the spread of infection. That would be to make the doubling time longer. So instead of doubling every 2 days, you're doubling every 4 days or 10 days or 2 weeks. The reason it's important to slow is it gives people, businesses, educational institutions, and critically the healthcare system time to prepare. It's especially important for the healthcare system. As you see in New York, the healthcare system has been completely overwhelmed, and that's what we're trying to prevent by social distancing and by slowing the spread of transmission. It's a very simple concept from the healthcare system perspective. 1 infection per day for 14 days is much easier to take care of than 14 infections in 1 day. All right, if we could have the next slide, please. So this is from the Washington Post on April 1st, so 2 days ago. And this, I think, gives us some reason to have some cautious optimism about what's going on here locally in the San Francisco Bay Area. The graph shows the number of cases per 100,000 people. The y-axis is numbers of people. The x-axis is time again, and you can see for New York City, 500 cases per 100,000. It's off the charts compared to anyone else. The graph also shows the time at which different places began to do social distancing. If you look at the San Francisco Bay Area, so March 14th, restaurants and public events were banned. On March 17th, we had an order to stay at home. So that was the earliest that was done of any place. And in this, we certainly cannot conclude yet that that's been effective completely, and that's why these cases are lower, but it does provide, I think, cautious optimism that we've got things into place that are going to end up helping us. The situation in New York, of course, is completely different because of population density and many, many other factors. All right, with that, that's our overview, and I'm going to turn this over to Jeremy and Josh.
All right, I think I'm unmuted. If I can get somebody giving me a thumbs up to say that they can hear me, awesome.
Yep.
So I'm going to kick it off for Josh and myself, and we're going to be talking about modeling, and modeling specifically to try to support resource planning and policy decisions. So next slide, please. The first thing to say is that to do this work requires a multidisciplinary, multi-institution, and generally a multinational team. And the current members that we're working most directly with are pictured here. So a big acknowledgement to them. I'm going to present the first part, but there's a lot of people doing a lot of hard work to make this happen. Next slide, please. So we're engaging with decision makers on this modeling. This is not an academic exercise where we're trying to get a paper out in a year or two. And we have efforts underway, collaborations, both in terms of with international governments and entities, with a specific focus on low and middle income countries, with a variety of state entities. We inked, as of last night, the contract with the state of California to do modeling for all of the counties in California, as well as with specifically focusing on incarcerated populations in state prisons, as well as work that Josh will focus on in just a few minutes, specifically with County of Santa Clara and other local counties, and the Stanford healthcare system. So next slide, please. So the purpose of the modeling is to address location-specific questions. How many infections, cases, hospitalizations, et cetera, will we have, and how quickly will they occur? What resources will be required to meet these needs? What will social distancing, other MPIs, and other targeted strategies do to address these outcomes? These are the kinds of questions that we're hearing over and over and over again from policymakers and other people who are planning for the systems that are going to address the current and emerging situation. Next slide, please. So our goal is to construct a flexible and scalable set of models. We start with data on the epidemiology, the pathophysiology, and specifically, and very importantly, the very different local situation, population density, population sizes, age structures, et cetera. And then click, please. As well as current capacities, interventions that are have been undertaken. And we construct a model that takes these data in, that sort of talks about transmission, as well as kind of demands on resources. And we put out a set of outcomes about what we think might happen, and try to talk about these things, including some gauge on uncertainty, or a range of possibilities, if you will. And then the last thing that we do, click please, is that we consider future strategies and interventions and how those might change these things. So the first green part is useful for resource planning under the current status quo, and the other ones are how would things change as we pull the various policy levers, or consider a bunch of different future scenarios. And so that's essentially the modeling framework, and the goal is to build it in a scalable, flexible way, because we're working with all of these different entities now, and we're anticipating that there's going to be additional demand for this work. Next slide, please. So just a couple of quick results. So here is from an unidentified state in Mexico, some outcomes on deaths, cumulative, infections, cumulative, and then sort of the daily rise and fall of infections, with a red superimposed hypothetical line sort of representing exceeding resources. And the point of this slide is to say that current interventions, social distancing, flattens the curve, as we would expect. However, they require us to have the resolve to live with these interventions longer. The length of the curve before it goes away is, under the blue line, the bottom panel, is substantially longer in the time dimension. And so we buy something with our patients, but our patients and our adaptation is costly. So interventions, especially if implemented early in the epidemic, allow us to prevent catastrophically overburdening systems. Next slide, please. The other thing that we've totally realized, please click. So this is just an example of some work that we've been doing on Brazil, is that decision makers do not have the time or interest to become modeling experts. They require accessible information displayed in comprehensible ways and the ability to interact with it and explore how their assumptions relate to the outcomes that they care about. And so one of the parts of our work are the tools and interfaces to allow decision makers to do that, as well as to tailor what we're doing to the local situation as much as we possibly can. So with that, I'm going to turn it over to Josh Salomon, and I'm going to mute myself.
Great, thanks, Jeremy. And can everybody hear me? Yeah, Anon, thanks. So I just wanted to start by briefly summarizing some of the work that we're doing more locally. And so that's with policymakers at Santa Clara County, the health officials there, as well as folks here at Stanford's Medical Center. And along the way, I want to add a bit to the observations that, that we've already started off with about the role of modeling in the COVID response. So we've been working closely with people here at Stanford Healthcare and at the County Health Department. And this, as others have emphasized already, is part of much larger efforts that involve many, many people to try to coordinate data and analytics that are useful for decision-making and for planning. And that's planning for surge, as well as for broader policies like the public health orders in place. So the analytic questions for both the county and the health system decision makers that we've been talking with are the ones that Jeremy has highlighted already. What's the current state of the epidemic in terms of its spread and the consequences, illnesses, hospitalizations, and deaths? And where is the epidemic heading over the next week and month and several months? What does that mean for likely demands for acute care and for the available supply to meet that demand? And how are public health measures that are in place or being considered likely to change that course and change those demands? And then finally, of course, a question that's important to all of us and on everybody's mind: when and how can the measures in place be relaxed and replaced with other measures? And decision makers all over right now need to answer these questions, and they need to do that with a combination of three things. One is the data that we can get from existing systems. The second, which we're talking about right now, models as tools for synthesizing those, and especially for translating those into forecasts and scenario analyses. And then three, what are possible sources of new information that we can most urgently use to improve our ability to make good decisions and to help? And so let me just spin through each of these very, very quickly. So what you see on this slide are a couple of dashboards, actually still on the last slide, if you don't mind, Beth, a couple of dashboards that the county is now publishing and updating that are good illustrations of the existing information sources. So on the left, you can see surveillance data that tracks tests and confirmed cases and deaths or hospitalizations where those can be tracked. The right are the administrative data that we get from the facilities. And so those in more detail tell us how many people are hospitalized, how many in ICUs, how many need and are using ventilators, what's the additional capacity we might need. Next slide, please. So modeling comes in as a tool that can help bring these different pieces of information together and to use them to try to play things forward under different scenarios. And so these are examples from Santa Clara County. We start with the data. These are confirmed case counts in the blue series there. And we know that these confirmed cases represent some fraction of all the cases in the county, but we don't know exactly what that fraction is. Click, please. So with a simple epidemiologic model, we can both reconstruct that case count using parameters that are driven by data that we have, and those govern transmission, they govern the infection process. How long does it take for people to develop symptoms? How long to recover from there? How many people will they infect in the meantime? But they also let us kind of play those forward and to continuously reevaluate what the models are saying as new data come out. So those were models fit through before the measures went into place. And if you click, please, you can see how those models can align with, but also be reevaluated as we get new information. And those two lines are just two examples of scenarios. One, a counterfactual, what we might have seen in a continued rise had we not acted to put measures in place? And then we can play out a number of different alternatives in terms of what the measures might be having in terms of changing those curves. And so if you could click through really quickly, really importantly, the models don't tell us the answers to major uncertainties. We need data to resolve a lot of those uncertainties. But what the models can do is let us trace out what are the implications of those uncertainties and to examine what might be different plausible trajectories that reflect a range of outcomes that we might see. And so this is just 3 outcomes playing forward another month in time, kind of fitting the data through this week. And these are just examples of scenarios in which collectively as a community, as a county, we're able to bring together low, medium, or high adherence to the measures aimed to reduce contacts and reduce spread. And you can see what those imply over the month in terms of 3 possible scenarios kind of along those lines. And so this is kind of models as what-if calculators, and I think one of the principal uses of those, and especially pointing where new information is most needed and can inform decisions. Next slide, please. And I'm going to wrap with just a couple of observations. One is that epidemiologic models and modeling have been central to policy discussions around COVID and the response to COVID in a way that I've never seen before and I think is simply unprecedented. And that's good because models are important and needed. And it's bad because there's also been a proliferation of models, some of that useful, some of it less useful, and it's quite difficult to sort through and know which is which. There's also been alongside that a proliferation of, I think, unrealistic expectations about what models can and should do, and a lot of misunderstanding about how results should be interpreted and used. And so on that note, I just want to leave you with a quote from this piece that was published yesterday by Zeynep Tufekci in The Atlantic, and I think summarizes this very nicely. And by the way, if you're not reading The Atlantic right now, you're missing some incredible journalism. But I think this quote really summarizes very clearly and concisely what I think is both the misinterpretation, but then the utility of models. So if epidemiologic models don't give us uncertainty, and asking them to do so would be a big mistake. What good are they? And the answer given, which I agree with, is epidemiology gives us something more important, which is agency to identify and calibrate our actions with the goal of shaping our future. Thank you very much. Passing it back over.
The U.S., we got a late start. Before people say ready, set, go, they were already preparing for it. So when people say go, they were running. They quickly went on the airplanes of people who were coming from Wuhan. Before they deplane, they checked their symptoms. So they were very vigilant in detecting possible infections coming in. They activated the National Health Command Center that they had set up after SARS in 2004. That allows the government basically to have interagency coordination. And then they use big data, and they integrated the data set from the National Health Insurance Program with the data set from the Immigration and Customs database. So when a doctor sees a patient, it was said that this patient has been traveling to different countries because they got the immigration data. For example, if you have people coming from Wuhan, where the epicenter, they will ask more questions about if they had fever or cough, and they may order a COVID-19 test. So they integrated the data, they used it for disease detection. Officials will call these travelers under quarantine 2 or 3 times a day to make sure their symptoms didn't get worse. And if they get worse, they will help them to get to the doctors. If they didn't, they continue to stay home and they will bring them food. If they break quarantine, let's say they decided to go out, the government will go after them and they will give them a big fine. So more recently, they started to pay people during quarantine. So you're getting paid to stay home, basically, if you're under quarantine. So that, then people wouldn't worry about food or housing. Government took control of making masks and distribute them because they realized that this is a critical materials for fighting this epidemic. So really, that they block a lot of people from coming to the hospitals if they have symptoms. And then if they have fever, they are triaged to another place, right, to be taken care of in another place. And so these kind of policies and procedures are ongoing in every single institution. And certainly in public buildings, when you walk in, there's a scanner, and it could tell if you have fever on the computer. Okay, this person has fever, you gotta take a temperature, you can't go into the building. And so those are the things that they're automating. I mean, their schools are open, kids go to school, and they have their temperature taken, but they go to school. I think a lot of the public health preparedness is about having the right infrastructure that you could activate during a crisis. And I think we have just been relaxed for the last decade, and certainly in the last few years that there's not been enough attention at both the federal government and some states to really prepare us for this a quick response. The U.S., we got a late start, so there's a lot of work right now in every single hospital, every single health care institution in the country preparing for this. Right now, we should take this lesson very seriously because it's going to hit us hard, but hopefully if everybody could do their part and stay home, the disease spread will get a lot slower, and then we could handle it. We will have a chance.
All right, looks like I'm up. Can you give me a wave if you can hear me? Yeah, great. So I want to cue off one of the themes in Jason's presentation, which is that Taiwan strategy was really centrally led and strongly led by the national government. The point I want to make is something that I spun out in an article yesterday in the New England Journal of Medicine, which is that in this country that is very hard to pull off because our Constitution sets up a structure dividing powers between the national, state, and local governments that really presents some challenges in times like this where we have a pandemic to deal with. And although the infrastructure problems that Jason mentioned, I think are important, our problems go way deeper. They are not just infrastructure, they are structure. They have to do with the way our government is set up. With our federal response to this virus so slow, confused, and confusing, states and localities, of course, have been at the leading edge of the public health response. But as we all know, they have exercised their public health powers very unevenly. And this slide, if I could have the next slide, Beth, I think illustrates the point. This is data today from the New York Times, or yesterday rather, illustrating when shelter-at-home orders went in place around the country. Ours went into place in Santa Clara County on March 16th, where we had really quite a low number of cases nationally. And as you can see, just a week later, there were more states with shelter-at-home orders, but still only 9 out of the 50, notwithstanding the fact that the number of cases had jumped over 44,000 cases nationally in a week. A week later, you see it starting to grow, but very slowly. Some states entering the fray tentatively with orders in place in only parts of the state, even though we again had a doubling of cases relative to the week before. And then this week, the March 30th spread looks like only still a little over half of the states at that point had orders in place, although we're now well over 160,000 cases by that point. So this is what federalism looks like in a pandemic. It's up to states and localities to be aggressive in reaction to a laconic and anemic federal response like the one that we have had, or to choose not to. And I think there are a number of factors that have led to the situation that we've been in. I think 3 are at the top of my mind. One is at the national level, the wrong people were put in charge and they made poor decisions, people without expertise who weren't listening to those who were. Second, they issued false and misleading statements early on that instead of having public sentiment well in favor of having governors and county health officers be aggressive, as we saw really in the opposite extreme during the Ebola outbreak, public sentiment went in the other direction because the public was being falsely reassured that this was not going to be a significant threat to their health. And then third, national leaders giving undue weight to economic concerns with the tumbling stock market, again, really opting against any measures or encouraging governors to take steps that would impose undue hardship on families and businesses. And so as a result of those critical decisions at the national level, we lost those precious weeks in which containment was still an option. Now, what do we do about that? Our system provides very few avenues for holding health officials accountable for an anemic response or lack of action in response to a public health outbreak. You can't really sue them. You can choose not to reelect them, but the main structural mechanism that we have is, again, federalism, that states and counties can step in to fill the vacuum. And again, the problem with that mechanism is not all of them will, not all of them do. So that's really the dark side of our federal structure of government here, is it has led to this literal patchwork of state responses. No state has to do anything. They're free to drag their feet as much as they'd like. And so the defining feature of our response to this pandemic continues to be local action in response to a threat that lost its local character weeks ago. And that just sits in very striking contrast to the examples of all of the countries that we would characterize as successful in having stopped the outbreak. In each of those nations, Taiwan, South Korea, for example, it was a strong national strategy that made the critical difference here. So what can be done now? Again, containment is not really where we're at right now. We're in the mitigation stage, but I think there are several steps that the national government can and should do now to help us make up for lost time. Number one is stop undermining the resolve of governors who have done the right thing early on and are facing pressure to reopen business. The White House has tempered its message in that regard by shifting out from Easter to April 30th, but I don't believe any of the modelers Josh is working with would say April 30th is going to be the time when these orders are likely to be rescindable. So they need to be more fully transparent about where the data are pointing in terms of the length of this necessity. Second, they need to do more to make sure that CDC guidelines are more than guidelines, that they actually get implemented. So I think they need to convene governors and their health officers immediately to come up with a coordinated set of state responses, as well as a timeline and criteria for rolling back those social distancing orders as the data improve. That kind of unified decision-making, although it can't be done through command and control, the White House can't make those decisions, it can bring people together and provide political cover for state and local officials who are under enormous local pressure. It can create a framework for shared decision-making, and very importantly, that would also make it more possible to create a sensible allocation framework for the PPE and ventilators that are now seemingly being allocated based on absurd criteria. The third thing that can be done is that Congress can use its spending power to further encourage states to follow this uniform playbook for community mitigation. If in future relief packages, which I expect there will be, it can condition a portion of those funds, for example, on states having adhered to a prescribed set of public health orders and actually enforcing them. It can also threaten to withhold some federal funds, for example, from schools or highways, to states that don't go along with the playbook, and the constitutional basis for such a decision would be that those funds are given in order to create safe schools and safe highways. If you're engaging in public health practices that don't foster safety, it's reasonable to tie them to those decisions. Fourth, Congress could use its power over interstate commerce to regulate economic activities that affect the interstate spread of the virus. That is within the power of the federal government, as long as we're talking about regulation across borders. And one concrete step it could take is to address business practices of large companies that are operating across state lines to make sure that their workers receive adequate protection. For example, shipping and delivery businesses to ensure that those workers are receiving adequate protective equipment and sick pay and appropriate screening and testing. Fifth, it could really double down on provisioning. This has received a lot of attention in the news lately as well. It should. There's a lot more use that could be made of the Defense Production Act to step up production of PPE and ventilators among high quality manufacturers. And it goes without saying that those should be distributed on the basis of something other than political factors. Sixth, it should take stronger steps to prevent the spread within federal prisons, other correctional facilities, and immigration detention centers, as I think Paul's going to talk more about. And finally, it should consider implementing the interstate travel restrictions for persons who have a close exposure to or known infection with COVID. So in summary, lessons are hard to take away when we're in the beginning of this epidemic still, but I think one clear lesson is that when you are dealing with a virus of pandemic potential, this is not the time to fly the flag of local freedom. It's time for a very strong national strategy. We blew it, but I think there's still an opportunity to make up for lost time.
Hi, can everybody hear me okay? Okay, great, thank you. Next slide, please, Beth. I'm going to be presenting our work, which attempts to bridge health and security studies at FSI and at the med school through collaborations between political scientists, legal scholars, security experts, and health people, with a primary focus on extremely vulnerable populations. And our work on COVID-19 has been primarily focused on two populations of extreme vulnerability. Basically, families and children in U.S. immigration detention facilities, as well as addressing COVID-19 in low-resource communities and areas of violent conflict and political instability. Can I have the next slide? And just to review how children are treated in U.S. immigration detention, that generally they come across the border apprehended by Border Patrol, Customs and Border Protection. Virtually all families and children coming across the border look for Border Patrol agents to give themselves up to. They are not evading apprehension because they are seeking asylum and therefore enter Customs Border Protection facilities. Unaccompanied children go to the Office of Refugee Resettlement, or ORR, which is run by the Department of Health and Human Services. Families with children, basically a parent and children, will go to ICE, Immigration Control and Enforcement. And there are special cases like very pregnant women, people with significant chronic illnesses that may be released into the interior. Next slide. These are data from last year in which about 80,000 unaccompanied children came across the border last year and were apprehended by Border Patrol. Another 300,000 children came across the border and were apprehended as part of family units. This is by far the largest number of children coming across the border in US history. Next slide. So we're talking about prevention of COVID-19. How do you implement CDC guidelines like social distancing in a place like this? How do you begin to address the requirements of managing COVID-19 once it gets into a facility like this? And the answer, of course, is extremely difficult. And advocates for children and health advocates have begun to protest the lack of appropriate response by the government in these areas. Next slide. And several temporary restraining orders have been issued, one in June against Customs Border Protection, Border Patrol, after several child deaths had taken place. And then just last week, TROs were filed against ORR and ICE, and were granted Saturday night by a federal judge overseeing the treatment of children in U.S. border detention. I was appointed as the independent monitor, special expert to the federal court overseeing the treatment of kids in U.S. custody, and responsible for making independent assessment and assisting in ongoing mediation between the government, Border Patrol, ICE, ORR, and the legal advocates for children. And we have been very active using data analysis as well as inspection and negotiation to immediately improve the situation and reduce the numbers of children and families in custody to make them less vulnerable to COVID-19 getting into these facilities. Next slide. The second area that we've been extremely active with is how do you confront COVID-19 in areas of political instability and violent conflict. Basically here, we're talking about how pandemic control collides with the exercise of power. And you can see why FSI is an extremely important institution to help broker some of these linkages. And we're working with other institutions around the country, around the world, the American Academy of Arts and Sciences and international humanitarian organizations to address these issues. But one of the things that we are very interested in is the recognition that nothing tests a people's relationship with its government more than war and plague. How does political legitimacy play out in shaping the population's response to the recommendations for social distancing, hand washing, and quarantine in places that have very complicated political histories? The reason we're very interested in this is because in most of these settings, in fact, in the United States, the only alternative to political legitimacy in controlling pandemics is coercion. And we've seen over and over again the responsibility for controlling infectious outbreaks, pandemics, change from the Ministry of Health to the Army overnight. And we're tracking these relationships as part of our collaborative research activities. Next slide. We're also trying to reconfigure or reinterpret the social distancing and other recommendations for places that are going to be extremely difficult to observe any of the recommendations in real world settings. And one of the things that being considered, particularly people in Hopkins, colleagues in the London School of Hygiene Tropical Medicine, is what's being called radical shielding. It's reverse isolation of high-risk individuals. Generally, we try to isolate people who are sick. This is turning it upside down and trying to isolate the highest risk individuals who are well from coming into contact with people who may be infected in these communities. And we're doing this particularly in settings where we can task shift. On the next slide. Using community health worker systems where local people have been trained to take on a task that have generally fallen to professionals, doctors and nurses. This is a group we've been working with for a number of years in Highland, Guatemala. Stanford and FSI have been critical in shaping and sustaining these programs, and many FSI faculty and med school faculty have participated in these activities. And one of the things that has been very important has been the development of mobile technology to communicate, to keep track of the activities of the community health workers over now 20 villages. And our focus is not only to implement quickly practices and policies that will protect the people in these villages from the direct effects of COVID-19, getting sick and dying, but also the indirect effects that we are extremely worried about, that the community health workers have always been very focused on. And that's because we're talking about areas where losing a job, not being able to go out into your fields, or not being able to go to a market to sell your wares means starvation. Have the next slide. And here, where we're talking, this is a slide of the community health workers out distributing food supplements to families in great need. Although the virus is not yet hit, the expectation is that it's heading in this direction into these communities throughout rural Central America. Just to sum up, it's important that we recognize the utility, the importance of these activities, but we should also not lose sight of the fact that these strategies are grotesquely inadequate. I'm terrified of what the direct effects of what COVID-19 are going to do to my friends in these areas. I should mention I've been working in these communities since I was a sophomore in college, which was a long time ago. I am frightened about what the implications are going to be, both the direct and indirect effects. Hopefully someday soon there's going to be an effective treatment and ultimately a vaccine. But our analyses of health disparities have shown over and over again that in highly stratified societies, new efficacious interventions are far more likely to widen disparities than reduce them. As efficacy grows, so too does the burden on society to provide it equitably to all those in need. Given what we have all seen recently, the reality, however, sure seems like the better off are likely to be the first to get the new efficacy in question. A new antiviral vaccine, great, but watch out. Power revels in scarcity. We should right now be crafting policies that ensure equitable provision, which of course is not only an issue of scientific discovery, but also of justice. And especially given the special capabilities of FSI, it's an important reminder that the dual struggles, the struggle for efficacy and the struggle for justice, are always inextricably linked. Thanks.
Great. So we've got some questions. I'll take a couple that I think I can answer quickly, and then we'll spend a little bit more time on other questions. So Steve Krasner asks, aside from age and underlying condition, do we understand why some people are asymptomatic while others get severe disease? The answer to that, I think, Steve, is no. The death rate is highest in people who have comorbid conditions, as you said in your question, but we don't know. Another question from Catherine was about whether other health departments will have the COVID dashboards that Santa Clara County has. That's a health department by health department issue. And so I don't think we can answer that. We go up to the top. Colin asked, what do we think about the public mortality projections the administration briefed the other day? That's a great question. I'm going to let, I want Josh and Jeremy to see if they have any insights. You know, unfortunately, I think that those estimates might not be too far wrong, but we don't really know where they came from in terms of how the administration picked them. So let me just see, let me go to Josh first. Josh, do you have anything to add on that question?
There's a lot of chatter about those estimates. I think they were derived from a little bit of synthesis and a lot of cherry picking from a number of models that the White House task force had in front of them. And I think where there's an important debate that's going on has to do with how to really think about the uncertainty around those. There's a lot of attention to the IHME numbers, for example, because those are state level projections of deaths. And people have really started to pick at those. I think probably the most important thing to be careful about in reading those is that they are presented as if they're worst case scenarios, but some of the assumptions behind those include for states, for example, that haven't yet imposed very strong social distancing and other public health measures. There was an assumption that they would do so within a week, and we can already see that has failed to materialize in some states. So I think those projections are massively uncertain. I think they're contingent on certain assumptions, and I think we really need to be kind of interrogating those, but really more than that, taking the impetus from those to ensure that we continue to say how important it is that states and decision makers that have not yet acted decisively really need to do so, because everyday delay, I think one thing we don't need models to tell us is that everyday delay is going to make things worse.
Yeah, the only thing that I just wanted to add to that, I agree with what you said, is that it sort of speaks a little bit to the problem of how projections are used as if they're predictions of an unchangeable future. I think one of the things that is emphasized is that they depend very much on the actions that we take and the decisions that we make. And so instead of thinking of them as soothsaying about what will happen, they help us to think about how our choices might alter what might happen.
Thanks, Jeremy. I completely agree with that. Let's see. Catherine asked, if we only have hundreds of people in the ICUs, why are we anticipating a huge increase in creating new beds? The issue is that we don't know how many are coming. And we have flattened the curve, but the work that Jeremy and Josh are doing in part and others is to understand when the peak of the curve is going to happen. So we still do not know whether or not we are going to exceed ICU hospital capacity. There are other issues that are very pressing right now, which is personal protective equipment. So the answer is we don't know, and it may be 2 to 3 weeks or more when we hit our peak here, and we'll know more about that sort of day by day as more data comes in. And I want Larry Diamond ask, let's see, I just lost it. Where was it? When do you think it might be possible to begin to lift quarantine, and how might deactivation be phased in among social groups? Well, that is the multi-billion, perhaps trillion-dollar question. I think I'll give my 2 cents and then other people can chime in. I don't think we know. It's going to be somewhat trial and error. The models can help us. That's one of the things that Josh and Jeremy are going to be looking at is as you peel things off, what do you expect to happen? So it's a tremendously important question. And let me just flip over to Jeremy.
Yeah, I mean, I think the other thing that is very key there is a point that Josh emphasized, which is in order to do that, one of the key things that is almost certainly necessary is having the ability to measure and monitor broadly in the population. So that we reduce that uncertainty, both before the lifting happens and then after the lifting period, so we can react extremely rapidly if you get a second epidemic. And so those systems of being able to do that level of health monitoring have been and are being developed in other places in the world. Jason sort of talked about some of that in terms of Taiwan, but I haven't seen those movements broadly in the US yet.
Great, thanks, Jeremy. Mike, we're close to out of time. Do we want to call it here? Or let me know what you think about.
Maybe one last question, Doug.
Okay.
You can answer. I think we should let everybody go at one as we committed to. Yeah.
Okay. All right. So Steve Stedman, this is a question for you, Paul. Several poorer countries have declared emergencies and implemented social distancing. India and South Africa, yet your prescription raised a big question for many people being at subsistence level. Are some of the governments choosing strategies that might work in developed countries but might not work in undeveloped areas?
Yes, well, that is the question, and they are finding out very quickly whether it's likely to work or not, because at some point people will not comply with these orders. And non-compliance in many of these countries is being met by coercion, law enforcement. And that in itself creates new generators of political instability and new types of problems. To date, most of the experience has been that people are attempting to abide by the social distancing and reduced transportation usage. But that quickly evaporates, and the expectation it's going to be very difficult to maintain these kinds of lockdown strategies in areas that rely on day-to-day incomes for more than a week or so. And we're already beginning to see this break down.
Thank you very much, Paul. I just want to thank everybody on the panel. I want to close again by saying that, as Jeremy pointed out, we do have some agency here, and the actions that we take are very important. We can avert the worst case scenarios, that's clear. How well we can do, we don't know, but we need to work as hard as we can. And I just want to thank the group. I know that most of the folks at Stanford Health Policy, many have been working night and day for weeks. And with that, Mike, I'll turn it back over to you.